Good afternoon, Dr. K.P. Reddy. I am Dr. Krishna Prasad, Director of Prasad Netralaya, Udupi and Mangalore, Karnataka. So, I'll be just talking about there's something called trust band from Carl Zeiss, no financial interest. So, I think everybody knows about this, that how exactly we used to correct presbyopia, either by doing monovision, that means correcting the dominant eye for the non-dominant eye for the near vision, or other options like as Dr. Mathur said, that by either putting bifocal lens or creating multifocal treatment by LASIK treatment, or other options as she said that all camera rings by doing increased depth of focus, or you can do the combined approach. So this is a unique technology actually Carl Zeiss has been invented. Here the principle is depend upon is a combination of micro monovision and increased depth of focus. The treatment what we do is LASIK treatment with the help of either MEL 80 or MEL 90 LASIK. And the program will be done by CRS master computer system provided by the company. So what exactly we do in laser blended vision? So we correct the dominant eye for the distance vision, and we make the non-dominant eye myopic by 1.5 diopters. Not only we are correcting the dominant eye for the distance vision, we also increase the depth of focus by 1.5 diopters in both dominant and non-dominant eye. So how exactly we can do by how increase depth of focus? So it is by creating a controlled negative aberration in the cornea. So as I said, dominant eye will be corrected for distance vision, non-dominant eye corrected for near vision, making myopic by 1.5 diopters. And as I already said, there is something called blend zone, where exactly the fusion of the dominant and the non-dominant eye occurs, and the patient will maintain the binocular vision. So why actually we choose this micro monovision? As you all know that it is very easy to adapt. You might have seen in some squint patient, brain has got a special property to suppress the blur from one eye. So why can't we adapt to multifocal treatment easily? Like, as you all know that at least 10% of the patient never adapt to this multifocality, because simultaneously our brain will be receiving images from the distance and the images from the near vision also, so that it takes longer time to get adjusted. So as I already said that is a laser blended vision is nothing but a neural summation. Our brain has been, as you have already said, that naturally programmed to suppress the certain blur from one eye. So this is one more important thing what we notice in our patient. Normally binocular vision is confirmed. Now binocular vision is statistically much better than the monocular distance vision. See, if you check in the distance eye, like in dominant eye, the vision in that eye, even the patient reads 6 by 6, it may not be that sharp. When you tell him to open both eyes, always the binocular vision will be much sharper. This is once again due to creating the increased depth of focus. So since it is the treatment is always bilateral approach, then who are the patient can undergo this treatment? The patient with myopia, normally up to minus 8.5 diopters, hypermetropia up to 5.75 diopters. The one very important thing, even patient with emmetropia, those are having 6/6 vision in their both eyes, still we can do this treatment. In the astigmatism up to 3 diopters, but make sure that patient does not develop doesn't having cataract. So preoperative evaluation, routine pre-LASIK evaluation, I do with Atlas topographer with Visante OCT just to rule out any just to see for posterior float, to rule out any keratoconus. The very important thing is to test for dominant eye. I think everybody knows, but I follow that test. First you correct both the eye for distance vision. make a small aperture in both the hand. Ask him to stretch the both hands, see through that aperture, then try to close each eye one after the other. Then when you are closing one eye, suddenly patient will tell that I cannot able to see any distance object. That means that other eye is going to be the dominant eye. Then you can tell the patient, get that aperture immediately near to his eyes. He is going to get in directly into his dominant eye. Then very important step is testing for micromonovision. So this is very, very important. So as I already said that, now you know that which is your dominant eye, correct that eye for distance and make the non-dominant eye myopic by minus 1.5 diopters. Then you should always also ask the patient to open both eyes to see for distance vision and for near vision. Some patients, at least few percentage of the patient complain of cross blur. In such cases, you can still repeat this test just to confirm that patient will not have the problem later on. Still, you can convince him, you can do so more number of times this test. Suppose some percent of patients still they won't accept, normally I don't take them for the treatment. So, these are the planning. Normally, as I already said that, the program will be done through CRS master provided by the company. So, this is our experience. I have done more than 100 cases, but I showed you only about 40 cases. These are the 40 patients actually come for regular follow. So what I have noticed, none of the patients drop their distance vision not more than half a line. And one more thing, this graph really showing that even in non-dominant eye, 75% of the patient vision is better than 618 or up to 612. Why I am telling this? If you correct one eye for distance, other eye for near vision up to 1.5 diopter, normally patient will have a vision of 636 to 624. But since we are creating increased depth of focus, normally patient will have, even in non-dominant eye, 618 or 612 or better. Even few of my patients in non-dominant eye having vision of 6.9. And one more thing I wanted to tell you, always binocular vision will be much sharper than the uniocular vision. This is a small video. I think those are having femto, I think they can take out the flap from femto. Since I don't have femto, so I have used microteton from Amadeus 2. No financial interest. So I mark the cornea with the marker. Usual treatment, since I already said that it is a bilateral treatment, so you have to treat both the eyes. And one more thing what I just wanted to tell, see, when you are trying this treatment at around the age of 40 years, you may have to reduce the other eye, making the other eye myopic by around 1 diopter is more than sufficient. If the patient is around 50-55, you can little bit increase up to 0.25, that is around 1.75. If you increase still more, then the benefit of all this treatment will go. So coming to the summary, this laser blended vision definitely not depend on people's size. You can even think about, we just started doing even in the pseudophakics, and a wide range of power you can see, that is hypermetropic up to plus 5.75, myopic of up to minus 8.5 diopter. And very important thing what I have noticed, it has got a very good intermediate and near vision with good adaptability more than 95%. And no significant night vision problem and contrast sensitivity changes. This actually study has been done by even Dan Ralston. According to him, at least 93% of the patient they achieve stereo acuity within 200 seconds. So no significant night vision problem and the contrast sensitivity changes. Thank you.